Good afternoon. Good afternoon. Wow. Welcome, everybody, and welcome all to our last, did I say last? Last webinar. I can't believe this is our last webinar. My name is Comfort Momo, FGM stroke public health specialist here in the UK. With over 35 years experience working with women living with FGM, working very closely with professionals, government and the communities to end FGM by 2030. As some of you may know, our webinar started on the 5th of October, and we have had fantastic speakers from all over the world. And I've had a very interesting, thought-provoking and diverse session like bodily inscription, ethical relativism, subjectivities, cultural context and the law, mothers and daughters, continuity, love, fear and belonging. We also had sexuality and pleasure, beauty and pain, female genitalia as site of ambiguity and intervention, to mention but few. Just a reminder that you will be able to access our webinars via YouTube, and we are aiming for publication and will definitely get back to you all. A face-to-face follow-up at some point will be great after COVID, Mr. COVID. Again, as we know, unfortunately, Teams does not allow interaction with participants, and we would like it to be. So please put your questions in the question box for question and answer session, which will be coordinated by my co-host, Toby. Also, I would like to take this opportunity to give a big thank you to King's College London for their support, especially our expert IT and technical support, Brian, Taylor, and James. Thank you so much. We couldn't have done it without your support. Also, big thanks go to our speakers and to you, our participants. Our session today will look at racism, FGM studies, FGM and social media. We're supposed to have 4 panels today, but unfortunately, our last panel and speaker, Christina Julius, is unable to be with us today to speak on FGM and social media due to an emergency. We wish her well. We are so grateful to Evelyn Akkad for stepping in. Evelyn, in her video, tells us how she was introduced to FGM in the 70s, and she will be sharing some quotes from her book called The Excised. Our first and second panel will be led by Ava Chappelle, looking at the morbidity due to FGM, a scoping review, and the surgical management of FGM related morbidity, again a scoping review. Ava is a plastic and reconstructive surgeon and author of Plastic Surgeon Familiarity with FGM and Cutting in the US. And our third panel, led by Hilary Burridge. Hilary is a consultant sociologist and author of Eradicating FGM, a UK Perspective. Today is the last day of 16th day of activism against gender-based violence, as well as Human Rights Day. And I hope you have been able to orange the world in some way and raise awareness, according to the United Nations theme for 2020, Orange the World. Right, I was going to introduce our keynote speaker, but unfortunately she's not with us at the moment, but I will be introducing her later on. So I will give the floor to our first panel, Ava. Thank you.
Thank you so much. Good morning, everyone. My name is Ava Chappelle, and I am a plastic surgery resident at Northwestern Feinberg School of Medicine. And last year, I was the Institute for Global Health postdoctorate fellow at, and the majority of my studies were focused on female genital mutilation and kind of optimizing surgical care for these patients. And again, the ultimate goal is to end this practice of FGM, but while there are women and girls still suffering, we need to really improve our care for these individuals. So to begin, I have no disclosures. And briefly, I'm using the definition for this presentation and for all of my studies for FGM as all procedures involving partial or total removal of the female external genitalia or other injury to the female genital organs for non-medical issues. And as the United Nations Human Rights Council has stated, FGM is a human rights violation. The World Health Organization created a classification of FGM into 4 types, and one of our local artists worked with us this past year to create a new pictorial depiction of these 4 types. And so we can see with type 1 FGM, the partial or complete removal of the clitoral glands and or fold of the skin around the clitoral glands. With type 4, involving partial or complete removal of the clitoral glands and labia minora, with or without removal of the labia majora. And then type 3, referred to as infibulation or phoronic FGM, which involves an almost complete closure of the vaginal opening. And then type 4, which is more of the miscellaneous category of the various types of harms that can be caused to the female genital area. So there are many health associated risks with FGM, and these range from acute to chronic, and also with the severity of death. However, with all of these risks, over 200 million females live with FGM around the world, with 300 million estimated to be at risk every year. And in the United States, they're estimated to be 200,000 at risk every year, with over 500,000 women and girls living with FGM in the United States. And as I am living and working in Chicago, realizing that at least 20,000 women and girls are living in Illinois alone with FGM, this just clearly highlights how FGM is a significant global health issue. Now, while there are all these healthcare risks associated with FGM and a worldwide awareness of this, when we look at the current guidelines on surgical management for these complications for FGM, the World Health Organization in 2016 published recommendations and best practice statement summaries. And what was very disheartening for me at the beginning of my studies was realizing how all of these guidelines for deinfibulation during obstetric complications or antepartum or intrapartum time to facilitate childbirth, or even during urologic complications, these are all strong or conditional recommendations with very low quality to no direct evidence. So again, realizing that there isn't much evidence or literature out there to really guide healthcare practitioners in how to care for these patients in the best way. And then even looking at mental health guidelines, again, we see conditional recommendations with no direct evidence. And then for female sexual health, conditional recommendations with no direct evidence. So really, there's a lot of work that has to be done by healthcare providers, researchers, advocates to improve the guidelines and availability of these guidelines for practitioners around the world to more optimally care for these women and girls. And so in kind of beginning my studies on trying to understand what kind of surgical care is available for this special patient population, the most recent systematic review by Berg et al. In 2017 looked at the effectiveness of surgical interventions, and they really could only come up with 3 major interventions: defibrillation, clitoral reconstruction, and cyst excision. And looking at only these 3 types of interventions, most of the evidence was for defibrillation, which basically was found to be helpful in preventing cesarean sections for women with obstructed labor. But for clitoral reconstruction, the evidence was pretty, not just anecdotal, but really not enough to give realistic expectations and proper informed consent for patients prior to that. And then for cyst excision, it was essentially, there didn't seem to be issues, but there really wasn't much data around it. So the 2 areas of focus for the projects I'm presenting today are: 1, to establish a comprehensive review of the reported medical, both emotional and physical complications for FGM, and then identify the gaps in available surgical care for FGM-related morbidities. And the methods that we used were a scoping literature review for both of these questions. And essentially looking at there are available systematic reviews, but as there really isn't much high-level evidence, it seems, we thought a scoping review was the most appropriate to really kind of synthesize and kind of characterize the data that's existing on FGM morbidity and FGM surgical interventions. So the first presentation is the project on morbidity due to FGM, which is a scoping review. And our objective is to provide the first systematic scoping review of the existing FGM literature to characterize this literature on all physical and mental health related morbidity, looking at author affiliation, country of origin, and what are the morbidities being described. And the aims are to demonstrate the common mental and physical FGM-related morbidities and characterize this literature. So we conducted a formal systematic scoping review search of 8 electronic databases, and we included all primary source journal articles, so from case reports to the level of randomized controlled trials, if they existed. These were all literature that were available in English language and had to be accessible online through interlibrary loan or through our library. And so here's our diagram showing that over 6,700 articles were initially captured, and then 257 were included for our qualitative synthesis. And notably, when we look at the study design, the majority of these articles were case series, cross-sectional studies or descriptive studies with really very limited higher level studies, and then no level 1 or level 2 studies that were captured. And we included all primary source articles. In terms of the years of publication, we did see that over the past 10 years, there is this, well, over the past 20 years, a steady, seemingly more increase in the number of publications per year. And definitely the past 10 years, there have been more. So we could see that as arguably a more increased awareness in publishing and researching and reporting FGM-related morbidity. And this is a map showing where the articles came from that we captured in our scoping review. And the darker green are the countries from where more articles came from. And Nigeria had the highest number of articles, 37, followed by the United States at 35. Egypt with 23, Sudan with 13, the United Kingdom with 13, and those were really the countries with the most articles. When we looked at specialty affiliation, as anticipated, obstetrics and gynecology had the most number of articles, followed by public health, global health, population health, specialties, then psychiatry and psychology, and nursing and midwifery. And then when we look at the morbidity type and chronicity that were reported, physical long-term morbidities were most frequently reported in the literature. And then this is a bit of a kind of a busy slide, but we tried to distill and collect all the specific morbidities that were reported. In the table on the left, we have the physical and emotional, and then both types of outcomes. And the physical outcomes, the most reported were obstetric and reproductive health issues, cysts, urologic health issues, blood loss, infection, vaginal obstruction, and pain. And then actually sexual dysfunction was the next most reported morbidity, followed by an emotional health, mental health issues, interpersonal relationship strain, anxiety, PTSD, and depression. And we really felt that this sexual dysfunction fits in both of these spheres, as it really incorporates both physical and emotional health issues and is a highly reported morbidity. And what we found that this really relates to the growing awareness of the utmost importance of a multidisciplinary approach to helping women and girls living with FGM recover and heal. That even if you are treating a physical long-term morbidity, there is an emotional component to that, and that may be manifesting as sexual dysfunction or other disabilities. And so really the importance of multidisciplinary care for these individuals is critical. And so to summarize, this was the first scoping review to really capture all the primary source literature on FGM-related physical and emotional morbidity. We saw mainly physical chronic morbidities reported with lower level evidence at the mainly descriptive study level with a focus on reproductive health. However, these papers came from 43 different countries, from spanning 27 specialties, and there seemed to be a growing number of publications each year with also psychiatry and psychology present in the mix. So I think, again, the importance of multidisciplinary care, and I think that we are slowly getting there. Now for the next project, this was the surgical management of female genital mutilation related morbidity, a scoping review, and this focused more on the surgical intervention component. And again, we conducted a scoping review using the methodology in the PRISMA extension for scoping reviews. We included, again, all English language literature. So if an article was available in English translation, then of course we could use it, that has been published on surgical interventions to treat morbidity related to FGM. And in this study, we initially captured 7,000 articles and included 190 for our qualitative synthesis. And in this study, we did include systematic reviews and also editorials, expert opinions for this type of scoping review. And in this case, we found the majority were level 5 evidence with case reports, editorials, and expert opinions most frequently seen. And then we did not see any level 1 studies, but there were level 2 in terms of systematic reviews and meta-analyses. And this is a kind of a busy table. There are a series of busy tables to follow of what we found. And when we sorted out all of the 190 articles, we came up with these main themes for surgical interventions: defibulation, cyst and stone excision, reconstruction, clitoral and vulvar, episiotomy, urologic intervention, labial adhesion release, reinfibulation, C-section, neuroma excision, keloid excision, retained objects, obstetric wounds, and there was one case of necrotizing fasciitis in a young girl. And so from here, we see the breakdown of affiliation of specialty affiliations for these papers, and we do see OBGYN was the most frequently seen author of these surgical intervention papers, followed by urology, plastic surgery, and then nursing and midwifery. And for countries of origin, United States had the most articles, followed by Nigeria, the United Kingdom, France, Switzerland, and then Saudi Arabia were the leaders in this literature. And when we look at the number of publications for sorted into 5-year bins, we again see that over the past 5 years, from 2015 to 2019, there were the highest number of publications on surgical interventions for FGM. And there does seem to be an increase in each of these 5-year bins in the number of articles published. And then for each type of surgical intervention, we really focused on the collection of articles to look at how many primary source studies, the non-primary source studies, the affiliations that are focusing on this type of intervention, and the countries where this is reported. So de-infibulation was the most highly reported surgical intervention, and this came from mostly primary source studies from the OB-GYN literature, and really that from the large retrospective reviews and case control studies that were reported here, defibrillation prior to or during delivery does seem to facilitate safer vaginal childbirth in type 3 FGM. And that's what really has came from this literature. And we did see earlier that the World Health Organization has given guidelines related to de-infibulation or defibrillation around for obstetric health reasons. And then when we look at cyst excision and stone excision morbidity, we see that there are mainly primary source studies here, a lot from OBGYN, and looking at this literature, we did not find much on long-term outcomes or follow-up, and mainly reports on that this was a successful practice of excision when this is encountered. When we look at the literature on clitoral and vulva reconstruction, we did find 32 articles on clitoral reconstruction alone with various techniques, and some of the largest collections of patients came from France with Pierre Fold's case series with over 1,000 patients. However, again, with the different types of clitoral reconstruction in these case series, the long-term follow-ups and outcomes weren't very well documented to really give that enough evidence for practitioners around the world to be able to well inform patients prior to this procedure. And we included clitoral keloids as well as clitoral neuromas in this collection because after excision, there is the potential need for a clitoral reconstruction. And that was something that was described within these articles. And then for vulva reconstruction, there were some articles on this with mainly from the OBGYN and plastic surgery literature. And this came from Germany, followed by Egypt, France, Turkey, and the United States. And then we also found, looking at the urologic interventions for FGM, these were all primary source studies, although only 12. And then for the urologic interventions, this ranged from urethral dilation to catheterization, urethral prolapse repair, and urethrolysis with neourethral reconstruction, with or without an autologous sling for these patients. And one thing of interest here, as there is this intimate relationship of the clitoris and labia minora to the urethral meatus, the urologic structures are at high risk from FGM. And one thing that did come up is surgical care for obstetric urethrovaginal fistulas, which was reported in 2 articles. One article was a case control study from the OBGYN literature of women treated at a fistula center in Ethiopia. And Browning et al. Found that FGM type 1 and 2 were not independent causative factors in the development of obstetric fistula, and that only their significant finding was the need for a pubococcygeal sling at the time of fistula repair. And then Burge et al. 6 years later presented a retrospective review of 78 women with FGM with type 2 and type 3 who had obstetric fistulas. And then they described methods for fistula repair that were either transvaginal and transvesical. And that women with FGM type 3 are more likely to need a transvesicular repair, which is more technically demanding and difficult for patients. And then we looked at for peripartum interventions for FGM and really combined episiotomy, C-section, and obstetric lacerations with this. And these were all primary source studies that involved a mix of observational with case control, case reporting, case series, and again, looking at peripartum interventions that basically their anterior episiotomy for FGM type 3 was found to be protective against anal sphincter tears and postpartum hemorrhages, and that this practice of an anterior episiotomy may be helpful for teaching more practitioners, nurses, and midwives who care for women with FGM with this technique. And then moving along, when we looked at labial adhesion release, there were enough articles of this particular type of intervention that we had its own category. There were 9 here, and this was a practice. Again, there are a variety of severity of labial adhesions after FGM, and then a release of this was found to be therapeutic. However, there was still there wasn't much on long-term follow-up or outcomes for long-term follow-up. And then looking at this miscellaneous category of retained objects, and then the one devastating case of necrotizing soft tissue infection. These were just, there was pieces from the initial event were retained and caused a chronic issue for these women that eventually developed into such severe pain and situation that they need to have it removed. And then necrotizing fasciitis was in a young girl who developed this terrible infection that she unfortunately passed away from. And finally, we did include articles on postpartum reinfibulation. And while this is not a surgical intervention for FGM morbidity, it was reported enough and it's controversial enough that we did include it in our study, as this is something that's very challenging for obstetric healthcare practitioners, because when after birth, if a defibrillation had to be done, what is the responsibility to re-infibulate or to not do anything, because both of these potentially can cause harm to that woman. In addition, there was a study that found even postpartum tightening for women who weren't initially infibulated, but after surgery, they underwent this tightening procedure. So again, looking at this really difficult area of the postpartum period and what's the responsibility of the healthcare provider to best do no harm to their patient. So to conclude, this is the first scoping review on all of the surgical interventions reported for FGM, and it really demonstrated the lack of high quality evidence on management, real limitations in terms of long-term outcomes reported and follow-up to guide best practice recommendations for these patients. And clearly FGM surgical care spans multiple specialties. It is a diverse, complex, and challenging to study, and goes beyond just cyst excision, defibrillation, and clitoral reconstruction. There's a lot more surgical care needed. And what is promising is there does seem to be more interest based on the volume of literature over the past years, again, from multiple different specialties in different countries. And that, just to highlight, as from the past study, again, this diverse morbidity associated with FGM encompasses physical, sexual, and psychological trauma. We can just keep on working towards this optimal multidisciplinary approach for these patients that involves the reconstructive surgeon, mental health care providers, specialized in trauma-informed care, special FGM gynecologist, midwife, urologist, and physical therapist. at minimum is recommended. I want to acknowledge all the wonderful people I worked with on these projects, and definitely we have two fantastic research librarians at Northwestern Galter Health Science Library, and some references. And thank you all for your time and attention. I'm very thankful to be here today.
Thank you.
And I'm wondering if now we can proceed to have 2 or 3 questions. Is that possible?
Yes, before then, Toby, can I just quickly say thank you so much, Ava. Very interesting studies and findings. And I really agree with you. Yes, we still have lots more to learn in terms of surgical care. Because for someone who perform average of 1 defibrilation every week, when I was at Guy's and St. Thomas's, the need for that is there in terms of labor and delivery, but we still need to do more in terms of learning in other form of surgical intervention, which is very key and very important for these women we care for. And thank you so much for this. Yeah, over to you, Toby.
Yes, I wanted to thank you also, Ava. It was highly enlightening for me, the professional medical side of it, because I've been mainly concerned with the testimony of those who have undergone FGM, the way they write about it or the way they express themselves. And in fact, I'm coming from the Francophone expression here. So I guess one of my questions that I asked, but there are 2 that I'd like you to consider. You explicitly told us you had focused on English language sources, which makes a lot of sense because there are quite a few of those. But speaking as a layperson and with a specialty in literature, I found that the Francophone approach to Reconstruction, especially, is different. And I'm just wondering if you made a conscious decision not to go there, or whether it's the choice of English was based on other criteria.
So in terms of the Francophone approach, is there a specific author or because
Dr. Pierre Fauldes.
Yes. So we did include Dr. Folds, his clitoral reconstruction, his studies. Those were included. So as long as there was enough, either English translation or we could really interpret enough, we included those. I think there were some articles that even the abstracts and everything, it was in such a foreign language, to failure of a better word, that we did not include, but we did include Pierre Folds in the Francophone. But I do think that was a decision that had to come from just we just had to make that decision, that we had 190 articles that really we did capture from around the world and made sure to include Pierre Folds. But ultimately, I think if I were to follow up in one area and narrow down a bit, I would be open to definitely any language and then working with a translator and going through that if needed.
Yeah, thank you. Another really good question concerns the ethnicity and the religious identities of patients, and if you found linkages with type of FGM. Did you look for linkages in that respect?
So we did not do an analysis that kind of looked at the types of FGM with the interventions reported. We did not do that separate analysis. Definitely articles that were captured had that, and what they found, particularly for type 3 FGM and type 2, related to the need for defibrillation and that practice. And I think that for clitoral reconstruction, that was basically for all types available, but that is an analysis that we did not do particularly.
Mhm. Thank you. Do we have time for one more?
Yes, continue, please.
Yeah. Okay. So I was wondering, but I think you've just answered it. Nonetheless, concerning the motives of patients seeking treatment beyond pain, were there other motives? And I guess where I'm headed with this, the dangers that they may have been confronted with by seeking treatment. Social.
So, yes, I did not find any article that described a negative consequence of seeking treatment for something other than pain. The articles did describe, wanting for improved sexual function, kind of self-esteem, or even some women sought defibrillation to have penetrative intercourse after this happened. So that those various reasons were reported, but there was nothing that I found that said a woman was punished or harmed after seeking a clitoral reconstruction. But what was interesting, there was a study that looked at comparing women with sexual dysfunction in FGM who had clitoral reconstruction and sexual therapy and counseling, and women who just had sexual therapy and counseling. And they found, I think, that women did better with the sexual therapy and counseling. And so, again, going towards that real emotional component with sexuality and health. But we are also looking at the effect of vulvar kind of aesthetics. And it's not just what something feels or if there feels like, but also what something looks like to you, to yourself.
Yeah. Thank you.
Right.
Okay.
Thank you so much.
you.
Thank you, Toby. Ava, thank you so much for that. I think I like the link between fistula, which is reality for some of these women, and the laceration as well as the episiotomy as well. And the other thing that you mentioned, which is really still confusing for many professionals, is the typology. I know WHO tried to readdress that, coming up with type 1A, B, C, and so on, but it's still very confusing for many professionals, especially midwives that I work with. And I totally agree with you that we still need to do a lot in terms of the guidelines for professionals. I can see you nodding your head. Do you have any final words?
Can I come in for just a quick one? Ava, all the things you're saying are things that I'm glad to say I say too, because I totally agree. It's not just interdisciplinary, it's much more than that. It's holistic. We need to go. One thing that is, as you may know, I published my first book in 2015. And to be honest, although we know more to be true, though, we don't actually know much more in terms of the whole issues. What's happened is studies have confirmed what was suspected in the early studies, on the whole, not always, but on the whole. And I would say that that is because we're still looking at lenses. We're not actually understanding the whole issue. And I hope, I'm sure that you would, I think that in the end, we're going to have to drop disciplines when it comes to looking at it holistically and try and look at it as issues, rather than as particular. But I don't mean of course that we're going to have, policemen doing plastic surgery or whatever, not at all. But that we have to somehow move people into seeing that the whole is much greater than the bits. Does that make sense to you?
Yes, definitely.
Okay. Do you have any final words, Eva, before I call our next speaker?
Well, no, I just really want to thank everyone for the opportunity to share our studies this year and for your wonderful questions and comments. And yes, thank you so much.
Okay. Thank you so much, and thank you, Toby, for the Q&A session. I will be coming back to you later on. Right, it gave me great pleasure to invite our keynote speaker, and a great honor to introduce her, Professor Jackie Dunkley-Bent, OBE. Jackie is the very first Chief Midwifery Officer for England and the National Midwifery Safety Champion for the Department of Health. She has worked tirelessly as a midwife, as a nurse, and held senior position in clinical practice, education, leadership, and management, including Director of Midwifery and nursing positions for women's and children's services at Imperial College Healthcare Trust and Guy's and St. Thomas's NHS Foundation. Jackie is my mentor, a great friend, and I would like to take this opportunity, Jackie, to thank you for your dedication, resilience, your energy, your passion, vision, and mission for midwifery in maternity for midwifery and in maternity world, and for leading the way in England and worldwide. I salute you, my Shiro. Thank you for being you. Jackie's title today is The Impact of COVID on Maternity. Over to you, Jackie, Professor Jackie Dunkley-Bent, OBE.
Comfort, thank you, and thank you for that really warm welcome. And first of all, just to say a big thank you to you, actually, and apologies that I wasn't online when I was expected to be, and your team were perfect. My access was just a little bit challenging. And then to top it all off, the doorbell rang and I waved to the person to leave the parcel on the doorstep, and they said, "We need a word with you." But here we are, and thank you. And actually, you've been an inspiration to me. I'm going to start the talk, but you have been a true inspiration to me. And as you know, when anybody mentions FGM, I say, have you spoken to Dr. Comfort Momo? Because you're my go-to person, and through experience and education. But this isn't a mutual admiration brigade between me and you. We're going to start with the presentation. So thank you also to David for getting this uploaded so quickly. I had thought that I'd be able to share my own screen, but there we go. So on to the first slide then. So what I'm going to speak to you about is maternity and COVID, and just stepping into the COVID space for a moment. And we should be able to contextualize what that means for women and babies and women who have experienced female genital mutilation. So I don't know whether we have a national or international audience, but I'll presume that we have, unless I see a head shake from Comfort. So I'm going to presume that we have. So I'm just going to maybe be a little bit slower in terms of how I explain a few things. So we were doing incredibly well with our ambition to improve outcomes for mums and babies, reducing the mortality rate, perinatal and maternal, and intrapartum brain injury. And we have policy documents. Many of you in England, in the UK, will be familiar with Better Births, the report of the National Maternity Review. You can see it there for yourself on the screen. We are 4 years into a 5-year programme, but COVID is somewhat influenced year 4. We have the NHS long-term plan that was birthed early last year, and the interim people plan that is no longer interim anymore. And we were doing incredibly well with working with our key partners, working in collaboration, all about placing women and their families at the centre of everything that we do. And my ambition as the Chief Midwifery Officer in England was to ensure that England was the safest place in the world to be pregnant, to birth, and transition into parenthood. And now we're going to go on to a little story, because on the 30th of January this year, our world was about to change. And on the 11th of March, the reality hit and our world certainly changed. So I'm going to take you on a little bit of a journey about maternity care provision, how we coped, a little bit about the data, and I'm going to focus predominantly on Black, Asian and minority ethnic women. Next slide, please. So, like any good learning organisation who really care about their people, we were responsive to their needs. So our chief exec, Simon Stevens, wrote out to the system, maternity providers, hospitals, trusts, wherever you are in the world, we wrote out to hospitals and said, if you are delivering on a policy ambition, we are going to have to pause that and deal with the pandemic. So that was the national letter. Naturally, maternity followed suit. So the programs, the policy drivers that I showed you on the previous slide, we said to the system, we recognise that we all need to be hands on deck to deal with these uncharted territories. So therefore, we are deferring our programs until autumn 2020. Next slide, please. So at the peak of wave one, so just speaking in waves now as we work our way through, work our way with this virus. In wave one, at the peak, we had 74 trusts out of 130. So for those that aren't familiar with the English system, 130 maternity providers that we call trusts, located in hospitals, and 74 of them had suspended their home birth service. Why? Because we needed staff to be in a place where everybody could be kept safe, and there are enough staff to provide a safe service. That's against the backdrop of midwives and obstetricians and anaesthetists responding to COVID like we all have had to. Some have been sick, some have been shielding, and some have been looking after loved ones. So nonetheless, that culminated in 74 of our 130 trusts that suspended the home birth service. That wasn't without challenge, I have to say. At the point of writing the slides, there were 7 suspended, now we have 2, only 2. So we've come a long way. 28 of our midwifery-led units closed. That equaled 4 alongside midwifery-led units, 4 out of 112 in England, and 9 freestanding midwifery units, 9 out of 61 in England. And that was the reaction to the pandemic based on the staffing narrative that I've just shared with you. 2 of our obstetric units were also closed. So that was at wave 1, and now we are almost back to full opening of all our services. Naturally, elective caesarean sections had to be repurposed to independent providers who were on hand to support the NHS. Impact on staffing was variable, so we were supported. We had an emergency register, excellent support from the NMC to pull or to invite people back on to the register to contribute to staffing during this time. And that's just an indication. 770 and 2,970 students were also helping in some way. Many of you know in England, the third year students, the last 6 months of their education programme, we asked them to do an extended placement, and they were paid to do that to help us on the front line. Staff absences were in relation to COVID, impact on staffing, as I said, shielding, experiencing symptoms themselves or looking after loved ones. And then there were fears and concerns from BME staff, so Black, Asian and minority ethnic staff were exceptionally concerned as the disproportionate impact of COVID took hold and became a reality. Next slide. So the impact on women, that we had delays in some women accessing intervention, accessing care. Many women were fearful of acquiring COVID-19. If they had a concern, an anxiety, intuitively women would engage with maternity services in the COVID space. We had anecdotal accounts of women staying at home. And there is a degree of conjecture around an increase in stillbirth rate because of that fear and delayed care. HSIP, for those that aren't familiar with our English system, the Health Safety Investigation Branch, who investigate our serious incidents, they looked at a 2-month period last year and looked at the stillbirth rate and compared it with the 2-month period this year, and saw that the stillbirth rate had doubled, just about doubled during those 2-month periods. So they're doing a deep dive. They're looking analytically at the data, having a look at the cases to see what truly happened in that comparison, and is it about women not engaging, or is it about something else? So in response to some of these concerns from women who are fearful, we produced a range of materials to encourage people to engage with our services, and specifically reached out to the Black, Asian, minority ethnic communities. So the numbers of Black, Asian and minority ethnic women in hospital who were pregnant with COVID was of concern. So we reached out to those communities through women's networks, Muslim women's networks, Afro-Caribbean networks, to engage with them in that space, to remind them that their maternity service is for them. So let's go on to the next slide, because I really want to get on to very specific things. Naturally, from a national perspective, I received many complaints. Of course we did. When we suspend services, women are often thinking about, what about me? What's going to happen to me? So our complaints really centred around home birth suspensions, visiting restrictions, the choice offer, because when you close a service, you reduce the choice offer, and also we had staff concerns. Next slide. So we are really fortunate in England to have the UCOS study. That's the United Kingdom Obstetric Surveillance Study. It's the largest population-based cohort of pregnant women admitted to hospital with COVID-19 at the time of preparing these slides. So what the UCOS inquiry did, the UCOS study did, it considered the outcomes of pregnant women and their babies admitted to hospital in the UK. This is a published work, so we've got more recent data, but I'm sharing with you the published work because I can't share with you data that we are informed of week on week. But nonetheless, between the 1st of March and the 14th of April, these next data will relate to 427 pregnant women. Next slide, please. So I think the first thing to say is that, you know, and this is quite a difficult message for women to receive who are fearful, who are watching people die and feeling exceptionally vulnerable. It's difficult for them to embrace, I think, and women have shared this with me, that pregnant women are at no greater risk of severe illness from COVID-19 than the non-pregnant population. You know, we can give health messages, and I guess as health professionals, I frequently think about how is this message received and is it reassuring? I sometimes don't think that these messages are reassuring, but nonetheless, we have 6% of pregnant women who are hospitalised, and we have pregnancy is not associated with increased mortality. Flu, women are more likely, pregnant women are more likely to die from flu than they are from COVID-19. The significant thing about this slide is that 55% of pregnant women admitted to hospital with coronavirus were from a Black, Asian and minority ethnic background. So of that cohort that I mentioned, just over 50% of them were in hospital pregnant with COVID. Also, if you are black, this continues, if you are black, these data referred to were, so pregnant women that were black and pregnant and in hospital with COVID-19 were 8 times more likely to be in hospital with COVID-19. If you were Asian, you were 4 times more likely to be in hospital pregnant with COVID-19 than white counterparts. So that again was not terribly, of course it wouldn't be reassuring for women from black, Asian and minority ethnic backgrounds. And if we think in the FGM space, which is what this is all about today, I haven't got detailed data about whether any of these women had experienced FGM, but certainly the fact that over 50% of them were in hospital with COVID. It's an interesting fact as to how many of them had experienced FGM or knew of somebody that had. So these were startling stats, and these reminded us of the previous Embrace data that talked about and identified and showed us that if you're black, you are 5 times more likely to die in pregnancy. If you're of a socioeconomically disadvantaged background, 3 times more likely. And you know, similarly, a disproportionate number of, or rather, inequality in health outcome for babies too. 66% increased risk of neonatal death for Asian babies. And we can explain some of this away, can't we? Because we can, you know, there is data that suggests that if you are from a black African ethnicity, you are more likely to experience a degree of cardiovascular disease, hypertension, high BMI. Asian descent, you're more likely to, particularly South Asian, have close relative marriage, consanguinity in the maternity world, and therefore more likely to have a baby that has a congenital anomaly. Therefore, neonatal period tells a story. We also know that if you're black and Asian, South Asian, you are more likely than your white counterparts to have a very preterm birth. If you have a very preterm birth, you are more likely to experience stillbirth and more likely to experience neonatal death. Nonetheless, this is something, these data are telling us as healthcare professionals something about how we deploy our care and who we listen to when they raise concerns about how they're feeling. Next slide, please. So with regard to the UCOS study and the babies, we have some interesting data. 5 babies died. This is the cohort that I mentioned previously on 3 slides before this one, 427 pregnancies. So 5 babies died, 3 were stillborn and 2 neonatal deaths. 3 deaths were definitely unrelated to COVID-19 infection. You know, for 2 stillbirths, it was unclear. And 26% of infants were admitted to a neonatal intensive care unit. 74% of women gave birth at term. And the data goes on, but the most significant thing about these data that we have been able to reassure women, and the data speaks for itself, is transmission of COVID-19 to infants was and remains uncommon. Next slide, please. We're also fortunate, and I'm sure you'll all agree in the UK, I'm really pleased that these data were not continue to be reported during wave 1, wave 2, and will continue to be reported. So we're very fortunate to have the Embrace UK rapid report findings, again published data. So I'm sharing stuff with you that's safe to share. So this is again a published report, and looking at March to May this year. So the headlines, you can see for yourself the mortality rate, but in particular, pregnant and postpartum women do not appear to be at higher risk of COVID-19 than non-pregnant women. 33% of women, you know, and this is a statistic that always concerns me. When I look at Embrace reports, and I look at the percentage of care episodes that may if care had been different, the outcome may have been different. And then when I think about the mortality rate for Black and Asian mums and babies, I often think about the communication, who listens to who. It comes back to me about care episodes. If you raise a concern, is your concern listened to or not? So I've mentioned this before in the UCOS data, but the Embrace data has told us that of the 10 women who died of COVID-19, 8 died as a result of the disease, and 7 of those 8 were from a Black, Asian and minority ethnic background. So again, COVID has shone a light on inequality in health outcome in a way that we haven't heard before, despite previous Embrace reports. And so to address the excess risk faced by Black and Asian minority ethnic mums, there were key things that Embrace said that we had to do, and that is about inform them about a high risk to themselves and needing to seek help immediately, clinicians lowering the threshold by which they admit and refer for multidisciplinary referral, and reorganising services and being aware that BAME women are more at risk. And this kind of feeds into a 4-point plan that I published with the Matthew Jolly, National Clinical Director, the doctor half of me. We published a 4-point plan out to the system specifically for Black, Asian and minority ethnic women. Next slide, please. So the rapid report findings 2, mitigating actions. This is again, pregnant women need senior obstetric review who fall into what we consider to be a risk category. When you have 7 out of 8 women who have died from COVID being from a Black ethnic, minority ethnic background, we need to do something more to support these women and their babies to actually live. Although the mortality rate is small, for this group, it's disproportionate. So key interventions, I won't go through those. Let's go on to the next slide, because I think it's important that you hear about our response. So, you know, whilst our services have worked really hard to provide safe and personal maternity care, that's a mantra that runs, it's a golden thread that runs through all of our policy ambitions. We have had to be proportionate at scale and intensity to the level of need, and that's the Michael Marmot principle of proportionate universalism. You know, if there is a problem, you don't treat. If a part of the population are experiencing challenges, we don't treat. We don't continue to treat everybody the same. We have to be proportionate at scale and intensity that is equal to the level of need. And actually, with that Michael Marmot principle, I add in pace and intensity. Pace, because for my pregnant niece right now, she has said to me, Auntie Jackie, am I going to be one of those statistics? Why is this happening? She's done her homework, she's looked back, the gap has been widening since 2013. What are people doing in this space to reassure our loved ones, or even women thinking about being pregnant, about these startling statistics? So a few key things. We've co-produced communication materials for women and families, and co-production, co-creation is really important, because no care about me without me. We've taken that literally and worked with communities, Black, Asian and minority ethnic communities, to hear from them, what is it that you need to respond to a health message and engage. And so in particular, those 4 coronavirus leaflets in 11 different languages was a huge hit. We also did an animation, which has been really well received, and the animation was really reaching out to women and their families, encouraging them to engage with their maternity services. I was a part of the animation. I'm Black. the doctor half of me is white. I'm not saying that you have to be of a certain ethnicity to get a message across, but the evidence tells us that it certainly helps. 10 films about physical and mental health from Best Beginnings, and we supported Best Beginnings, the charity, in their work. What they found is that there are many films. They have lots and lots of videos, the Baby Buddy app. What they found is if you're women from a Black, Asian and minority ethnic background are more likely to engage with their films and the app more so than white counterparts. But that they didn't just stop there with their evaluation. They went one step further and found that not only did women engage from those ethnicities, they acted on the information that they received from those videos. So the 4-point plan, being purposeful and meaningful with our interventions. We have in recent times, over the last 8 weeks, we've asked local maternity systems, the SROs for local maternity systems, to act now and take 4 actions, and that is co-produce, co-create an operational policy to increase the support for Black, Asian and minority ethnic women. And that means lowering the threshold when a woman from, well, when any woman speaks to a health professional, we have a moral responsibility to listen and act accordingly. In this Black, Asian and minority ethnic space, we've asked people to lower the threshold for review. If somebody's breathless, don't explain it away under the guise of pregnancy. You know, when somebody shares a concern, listen. Don't just listen to people that look like you or speak like you. And so lower the threshold for multidisciplinary referral and admission to hospital. Reach out and reassure pregnant Black, Asian and minority ethnic women by tailoring communication. And this is where it's important to step into the space of the community. And I know Comfort did this really, really well in the FGM space with how do you get under the skin of a community? How do you get people to trust who you are and trust your messages? There's something about stepping into the context of where they're at. So we've asked our systems to do just that. Thirdly, the vitamin D. So we know that if you are non-white, or if you go out in daylight but cover up for religious reasons, we know the evidence tells us that you will be vitamin D deficient. And we know that if you are vitamin D deficient, that is a challenge on your immune system at a time when we all need our immune systems to be incredibly strong. So there's a conversation now that happens about vitamin D supplementation. And the 4th action that we've asked people to do in this space right now to help with reducing perinatal mortality, maternal mortality, is to record accurately. Record keeping is a professional responsibility. It's a part of the code. Record on maternity information systems, risk factors, ethnicity, postcode, comorbidities, BMI. We shouldn't be looking at somebody and guessing their ethnicity. And, you know, because if we do that, we're in trouble. So that's the 4-point plan. Everybody can do something right now. And what I really admire about the FGM space is that in England anyway, there isn't a maternity provider in the land that doesn't look at their population and then think about what intervention do I need to support people from different communities. And I know Comfort was very much involved in that situation whereby she, with others, looked at our community and thought, we have a potential high prevalence of FGM here, and therefore we have set up this service. We can do that for everything in our services, and Michael Marmot calls us to do that, and that's called proportionate universalism, where you know the people that you're serving. I consider myself to be a servant of the people. That's why I'm a midwife. People think differently, but I have a thought about this servitude, serving the people well. We serve the people well by knowing who they are, and then we can be purposeful and meaningful with our interventions. Next slide, please. More of the things that we have done in this space to help to reduce, shorten the gap in the inequality in health outcome. Indeed, we're thinking about equity in health outcome. So I've laboured the point already in this regard. Next slide, please. So I've done a quick canter through maternity responding to the pandemic. What I haven't shared, which is something really dear to my heart, is the staff concerns. So we have Black, Asian and minority ethnic midwives, doctors and other support services for maternity services in England who have raised concerns. So I have been on calls totaling the people attending totaling 1,500 Black, Asian and minority ethnic staff. Three webinars culminated in that number, and there were recurring themes about their anxiety working at this time, and it was related to the fact that every time, you know, the briefings that used to be on a regular basis, every time they saw the type of people that were dying, they were people that looked like them. That they were also thinking about the fact that I am serving my profession here by contributing significantly to somebody's maternity journey. Am I going home to kill my mother, my grandmother, my family? These were real concerns. There were also concerns about midwives feeling that there were racial undertones whereby they were pushed to hot areas or didn't feel that they were well protected with PPE. And so if you can imagine at wave one, when everybody was scared, everybody's still scared, but everybody was panicked, it was uncharted territory, people didn't know how things were going to pan out. And so these were real concerns from these midwives. So a thematic analysis was run on the feedback that was received, and there were, and there continues to be a focus on Black, Asian and minority ethnic staff. And that is even down to something as simple as test fitting. You know, have you passed your test fit? How many people fail? Are the masks appropriate? Is it one mask? Because we've all got different shaped faces, broad noses, big cheeks, small faces. You know, we've got, you know, our Southeast Asian colleagues that have smaller faces. You know, we've got people with, you know, and so the variety was not there. So, you know, even failing a fit test, what did that mean? What did that mean when you need people on the front line? What did that really mean? Were people sent off home? Were people put in the back office? You know, so these were real concerns. And what we've done, along with colleagues, my colleagues at NHS England, who've done an amazing job, you know, I won't name people, but there are so many initiatives, the test fitting in terms of masks, looking at having different masks, ensuring that there's appropriate Q&As that meet the context of Black, Asian and minority ethnic people in terms of the risk assessments, understanding why a community, somebody from a certain ethnic group might not want to share details about themselves when undertaking a risk assessment, and not drawing the conclusion that they're obstructive or belligerent. There are cultural reasons why certain people, and there's something about trust as well. So there was lots and lots of staff issues, but we're riding the wave with that. Dr. Gloria Rowland, Director of Midwifery in London, authored a report called Turning the Tide, and that was the report that captured the views of midwives in England, and I'm utilising the findings of that report to improve how the experiences of midwives working in our NHS. So I've had a quick canter through how COVID has impacted on our services. Everybody's worked tirelessly, and a huge, big, authentic thank you to everybody that's continuing to work. I myself am on the front line. I used to be at St Mary's Paddington, In London, I now do clinical shifts at the Rosie in Cambridge. So, you know, I was there last Thursday in my PPE, doing a water birth, you know, still supporting women to have choice, keeping myself safe. We're in it together, but the data tells a compelling story about where we need to focus our efforts. And from where I'm sitting, there's a universal offer for everybody, but we need to be purposeful at scale and intensity that is equal to the level of need. And that need right now is Black, Asian and minority ethnic people. So don't get me wrong, a universal offer for everybody, but at pace and intensity for groups that need it most. Thank you.
Wow. Thank you so much, Professor Jackie Dunkley-Bent, for this insight and for sharing the very useful information, data and outcome and the inequality. 4 key points, like you've mentioned, very important to lower the threshold, to reach out and to step into the space. Very important. I'll now give the floor to Toby to see if there are questions for Jackie, as well as if you have some information as well, or questions yourself. Thank you, Toby.
Okay, thank you. And thank you very much, Jackie. I found that stimulating and enlightening to a very high degree. There aren't too many questions, but I noticed in the memoirs that I deal with that a topic recurring again and again, I would call it almost universal in those that I've read by women with FGM, that they have been disappointed in their initial contact, especially with OBGYN in Europe. And I was wondering if you found that in any way contributing to a higher risk for pregnant women who had COVID, who presented at the hospital. Was there any relationship you might have seen between hesitancy to consult and the severity of outcome for these patients?
Yeah, I mean, that's certainly, this is why I mentioned the health safety investigation branch looked at, obviously very specific in relation to stillbirth over a 2-month period last year. And as I mentioned, they noticed that there were 24 stillbirths over a 2-month period last year. They've looked at the same period this year, and that number has gone up to 40. Now, you know, that they're doing the analysis on that. They're looking at the cases in that regard to look at trying to really, I mean, we're hypothesizing, I guess, that women don't engage because they're frightened of acquiring COVID. This is anecdotal, but HSIP, when they've completed their inquiry, we will definitely know what it was, how women were treated, and what was the outcome from the cases that they're looking at.
Mm-hmm. Thank you very much. I think that's all that we have. So back to you.
Toby, could I ask a question? Sorry, I didn't really formulate it.
Yeah.
Yeah, I have to join Toby and Comfort to say how, you know, struck I was by your presentation, because in a way you started out with that, you know, extraordinary statement about making England, yeah, to be the safest place in the world in which to give birth. And then you then went on to detail the many risks, the many obstacles in the way exactly of women, members of the BAME community. And in that kind of revelation, you know, concealed are the many challenges that you have to accomplish what you wish to be accomplishing. And my question is, because it ties up with so many, you know, underlying and difficult and societal issues, do you feel right now, whilst there is, I think, acknowledgement on the part of this government the particular challenges faced by the BAME community, do you feel that this will translate into the kind of support, the kind of resources that you require to address the immense number of issues that you need to be addressing? Will that political will be sustained post-pandemic?
Oh, absolutely, because it was there before. It was there before the pandemic, and the 5 times more likely Embrace published their data last year and the year before, so there is political will, and there's will from my organisation to ensure equity. And so I personally think that any leader in any of our countries, the ambition should be to make their place the safest place in the world to be pregnant, birth and transition into parenthood, whichever country anybody's in. The leader, I believe, should have that ambition, and then we work hard to try and ensure that there is equity. And every time we move forward, uncovering the stark statistics about what I've shared means that we have to work harder. We have to be purposeful, because nobody should be left behind. And that also fits in with the FGM space too. Very often marginalised groups, women that don't necessarily have a voice, find their own way. That's not good enough. That our health service in England is here for everybody. It is free at the point of entry, and everybody should receive the best. And it's trying to work with our systems to ensure that everybody delivers the best. It doesn't matter who you are, where you are, how you choose to identify yourself from a gender perspective, your colour. Everybody has to make that effort who works in the NHS.
Thank you.
Mm-hmm. Okay, thank you so much once again. Thank you, Jackie, and thank you, Toby. I'll now give the floor to Hilary. Please go ahead. Thank you.
Sorry, just a moment.
And I was very interested to read this article in The Economist, which was comparing the work that economists do and epidemiologists do, and it was looking at COVID. And it said, and I'll quote, "Confounding uncertainty in the modelling of the epidemic, notwithstanding, and assessing how the pandemic is reshaping the global economy, scholars have worked at great speed, producing hundreds of papers evaluating policy measures, analysing economic costs associated with outbreaks and lockdowns, and in fact have been doing good work in helping with the COVID situation." And I wanted to extrapolate from that to think about FGM as an epidemic as well, because it is true that there's been a lot of very good work in economics and COVID. So let's see how it fits in with FGM. And I would take as granted as given for this paper that we can count FGM as an epidemic too. Something where we've got hundreds of millions of people affected must surely be an epidemic. There's nothing more important than to make sure we get a rounded view of these sorts of things. No particular discipline can deal with anything as complex as FGM or even COVID on its own. But there are lots of obstacles to be faced up before we can get effective synergies between different approaches to what I think is a public health challenge. If we look at the different ways in which FGM comes to face us, we can see that's complicated. I've listed a few: personal, community, medical, health, social, faith and belief, economic, educational, legal, activist and campaigner, policy, national or political, international, global and human rights. All those things come into play very actively when we look at FGM, and they do tend to fit rather uneasily with each other at times. Different understandings produced a chasm between different people's perceptions, and we have to remember in all this that there is nothing more true than that the personal is political when it comes to FGM. It's one of the most difficult things to unpick for that reason. It is about literal, fundamental harm, what I call patriarchy incarnate, the imposition of some men's wills on the bodies of women and girls. Let's look through the different scenarios, different perspectives that we could have in this issue. We've got stakeholders, and for them, important things could be tradition, it could be community identity, it could be economic cycle of the community, it could be the need to attain adulthood and have rights, protect the girl. All these things and more are reasons that people want to do FGM. And just as the reasons vary, so do the drivers behind them, the fundamentals. How about if we look at the issue of those who attend to health? Well, we've got a very complex situation. As clinicians and health providers, most people know that FGM is very seriously a matter of harm. It doesn't enhance health, it doesn't enhance fertility, it doesn't do anything good. But traditional cutters, who also would be viewed by some as health providers or care providers, regard it not only as a source of income for themselves, but also as a requirement for girls to retain purity, adulthood, and generally become independent insofar as they can in their own community. The services of others, of course, will be more clinical, and they will claim that they can do FGM in a hygienic and pain-relieved sort of way. And then we have people in the first world, a small minority of physicians, who say that it's only a nick and they should do it to stop other ways of it happening, or that even cosmetic surgery is somehow different from FGM and one is permissible and the other isn't, and that's a difficult issue. Looking at campaigners, we have parents, siblings, including brothers, family, cutters, community faith believers, schools, the media at many levels, national politicians, NGOs. But really, all these things provide different perspectives, make it quite difficult, and we don't actually know how well any of those who want to stop it actually are effective, because some of them may find that in fact what they think is effective eradication of FGM is actually effective relocation of it to somewhere else, for instance, to some other form of harm, and where in fact it's a matter of the loss of purity in terms of those who provide the thing. We might have a situation where in fact the loss of bride price will mean that the family may pretend to want it to happen, to stop it, but they won't actually, because they're afraid of the loss of income. Or we may have politicians who say that they're in favour of stopping FGM, but in reality, they don't want to. They want the grants that come with stopping it, but they don't want to actually stop it, because politically that would be a very difficult thing for them to do. How do you put the case for keeping girls in school? How do you make the case that girls who've not had FGM are going to be more able to look after themselves, but they may in fact at the same time lose their right to land? How do you explain to people that are fearful of their ancestors that it'll be okay and you don't have to have FGM? How can you prove that? You can't. And so forth, it goes on. If we look at enforcers, we find that enforcement is always shaped by the perceptions and gender issues, so that what some people think of as rightful enforcement to others seems like an imposition This is true in all communities, not just in FGM practicing ones. And so we already have many, many issues about what it means to do FGM or what it means to stop it. That's all I want to say about that. Of course, there are many important organisations that have provided many, many documents, reports, recommendations about how to eradicate FGM, which is the point where we start here. The UN, FPA, UNICEF, WHO, they've all produced hundreds, if not thousands, of documents and much advice on this issue. But I looked at the World Bank. I looked at some of these documents online and was surprised, shall we say, to discover that a UNICEF paper, a very important one, has been shared, so it says on the screen, 535 times. The WHO one I looked at had been downloaded 1,637 times. The number of women and girls who have experienced FGM remains at 200 million. So those downloads and explorations are very, very tiny number compared to the number of people affected. Of course, there may be paper sharing and there may be other ways, but it clearly isn't reaching as many people as we would hope. And if you look at some joint programs and their impacts, and I want to say every single time that a girl is protected from FGM is of itself 100% valuable, but the impacts of a large joint program brought us 131 arrests, 123 cases brought to court, and 30 convictions or sanctions. In Britain, of course, there's been only one. 2,500 communities made public declarations of abandonment. 83 or 4,000 girls benefited from community building packages in 4,500 communities. And around 500,000 girls received health services. These are, again, tiny figures in terms of the number of people who have experienced FGM. Every single one of them is important, but in terms of experience, not much. And so we have an enormous challenge. And without doubting in any way the good intentions and good work of those who have been involved, there seems to be an awful lot still to be done. So my first question is, who needs to know what? What aren't we telling or sharing that we need to go? And FGM as a study does remain significantly disjointed. If we look at, and reasonably so in some ways, if we look at a midwife delivering a baby, she doesn't need a degree in anthropology, she needs one in midwifery. Community activists have much greater need to understand and have the trust of their community than to have a knowledge of international human rights. Teachers keeping his or her child's girl in school doesn't require a degree in law. Police officers have no necessity to have detailed grasp of infibulation. It's just leaders need far more rigorous insights into the scriptures than into strategies for the delivery of healthcare. I don't doubt any of that. But if FGM were a viral epidemic, and even if the epidemic could be halted by the production of a single vaccine, we wouldn't currently get there because the disjointing is so great that the parts don't come together. It requires complicated teamwork and many, many different skills and resources to deliver effectively. So if we're looking at general entreaties, professional leads, politicians, policymakers and both being asked to work together, we have a problem. It's not going to be enough. There's not enough of us looking as a whole at the knowledge, expertise, insights and tools that between us we all need and have. Sorts of questions we need to ask are, why did this work, that didn't? Why did this, will this strategy or that approach deliver a better outcome than the other one? Do we have tools to tell us what X or Y will have greater impact? And on what elements of the challenge will it have the most impact? Are we actually clear about the factors in given situations most likely to be ameliorated by such and such an approach? And have we actually identified which of the critical elements of any particular FGM scenario are most susceptible, and to what degree if we use a given technique or approach? Mostly we don't know the answers. We try our best to guess and try our best to be guided by what we see, but we don't actually know. An example is, for instance, a previous presentation today by Chappelle and co, who say that they're still looking at the actual real impact in terms of morbidity of FGM. There's a lot to be done there still. Recommendations that the Royal College of Gynecologists have made in Britain suggest we need to know more about the rates of stillbirth and neonatal death. Excuse me. Interventional trials to assess the role of defibrillation, clinical trials to investigate the safety and effectiveness of clitoral reconstruction, the role of psychological assessment and treatment in antenatal care. And those are just clinical questions before we get to any more. There's a lot we don't know. So one way I think we could address that is to have SGM as a study in its own right. When you bring things together, medicine, education, law, whatever, social sciences, you get a much more coherent view. But to do that, you have to bring the actual academics and other specialists together to do it. I think that, in short, what is required is an additional level of FGM and its impact and challenges when we're looking at it. It's time to join the dots to develop the field or discipline of FGM studies, both as a research enterprise and, equally important, as part of the curriculum at whatever level is appropriate in relevant training, undergraduate and postgraduate courses. We need coherence. And the absence of such a dedicated field makes effective coordination and meaningful treatment measurement of treatment on the impacts of FGM much more difficult to assess. But there's little interdisciplinary research. There may be joint guidance, but there is not a route to exploratory and open-ended questioning of what happens and why. People who are dealing with FGM on the ground cannot be expected to investigate and scrutinise everything they're involved in. But the need for such investigation and scrutiny is still there. At the moment, such inquiries are generally conducted only at very high levels. Others will ultimately decide, but I think that there are things that we definitely need to bring together. We need to bring together health, socioeconomic, legal and educational issues, and we also need to bring together different perspectives on FGM eradication. What fits what situation? These are things we've been talking about previously. We need case studies which illustrate varied approaches to eradication in different contexts. We need formal invitation and guidance on how to find out more at a global as well as a local and national level. And importantly, we need guidance on the monitoring and evaluation of end FGM programmes. From all this, I would hope to see a much more active interest in identifying the gaps in our understanding and knowledge. Not only bringing together across the board what is known, but also routine interrogation of that knowledge, bringing themes and threads together to learn more about the optimum ways in which to make FGM and, as far as possible, other gendered violence history. It seems likely that more academics standing at a distance will have the space to ask wider-ranging questions, to spend time piecing together the evidence from different corners of the action. In fact, to create a paradigm for FGM, which brings together the multiple layers and paradoxes of this most chameleon of harmful practices, a practice which, in the word of the Kenyan prosecutor, Christine Njala, says is struggling to remain relevant and as a result keeps on changing every single day. A chameleon is hard to keep an eye on unless we know what we're looking at and looking for. We've already noted that there are 200 million women and girls alive today who experienced FGM and another anticipated 3 million expected every year to undergo the procedure for the next few years. There is no attempt or need or acceptable competition between different sorts of illnesses and conditions, but let's put that against the 70 million confirmed cases of COVID with a recorded 1.5 million deaths. With COVID, there are probably many more unrecorded instances, probably in the developing world. And yes, COVID is gender specific in that, in summary, more men die, but more women are impoverished. Looking at this a bit more closely, COVID is a viral condition easily contexted by clinicians, whilst FGM results in different sorts of contagion, human agency, which is less easy to conceptualize. COVID-19 has come from nowhere, though virologists are less surprised than the rest of us. FGM is a perennial plague for which vaccination will never be dramatic and acclaimed response. We're not going to get there that way. COVID will harm anyone. Nobody knows who's next. FGM harms only generally defenseless girls and young women who mostly live in far away places where a full medical response is in any case almost impossible. COVID is known to kill more older minority ethnic men and to cause more long-term harm to older women, but the initial effective reach of current vaccination programs is likely to speak to less impoverished white people. These observations may lead us to conclude that yet again serious medical responses in the first instance will serve certain sections of the community better than other sections, and in some cases will carry on doing exactly that. We can debate at some later date the relevant responsibilities of clinicians, researchers, commercial pharma companies and politicians in the uneven response, but what is immediately clear is that efforts to eradicate FGM, 200 million sufferers, with another 300 million more annually, have been far less well funded and supported than those to control COVID-19, with its also many sufferers, but an expected drop year on year. COVID-19 could be tackled immediately because every element of the required response was already available in an academic field: virology, epidemiology, big pharma development, economic, legal and social structures. All could be brought to play immediately, but none of these fields has been geared to provide synergy with a detectable framework to eradicate FGM. There is, however, one academic or research field which has the capacity to address both conditions. It's not yet been brought fully into play in many places. That is the Cinderella science of public health. In various first world countries, including Britain, public health has been significantly downgraded over many years, and in many developing countries, the field does not currently have the required capacity to be effective. In the first world, which would ideally inform the work also of less advantaged countries, this has been deliberate choice. Public health has been downgraded, and it studies the impacts of poverty as a major theme. Perhaps we should ask if it is politically expedient to leave the subversive focus of public health with as little political support and influence as possible. Am I being cynical? As we've seen, one difference between responses to, say, COVID-19 and FGM is that there exists no previously existing academic field home to consider FGM. There seems to be little urgency where it matters when it comes to FGM. Some of this hesitancy about or simple refusal to consider FGM can be attributed directly to funding, but much of it is also around a lack of interdisciplinary organisation to address the issues. Funding won't arrive if you don't ask for it. It won't arrive gratuitously. FGM is an enduring and fundamental assault on human rights. For some, a desperately sad, life-changing experience, a practice which alters the dynamics of whole communities and a massive economic cost at every level of society. A meaningful challenge to FGM requires acknowledgement that it is a stark exemplar of patriarchy incarnate, the imposition of some men's will on female bodies, and it requires too as much concern for human rights in other parts of the globe as in the first world. The good news is that if they wished, academics in relatively privileged positions could do much to make FGM the focus of concern to which 200 million and rising women are entitled. Multi-agency guidelines at whatever level of application are no substitute for genuine inquiry and serious impact assessment. Obstacles to genuine interdisciplinary collaboration, such as those identified in the Economist's commentary, which we just referred to, must be recognised and addressed. The Economist suggests, for instance, that different disciplines have different way of marking their lead thinkers, and that might be a problem. But a field of study should not exist just to enhance the stature of those who subscribe to it. The time has come for development of impactful FGM studies to be shared across the relevant curricula and beyond that to those who work so hard on the ground. Who will join us if we have an association for female genital mutilation studies? Thank you.
Thank you so much, Hilary. Joining the dots. We need to join the dots. It's very, very crucial and very important at this stage. As they say, it takes a village to raise a child, and I strongly believe that it will take families, professionals, communities, and the government to support this campaign in order to end FGM. You're very right in saying, obviously, we still need lots of work to be done. The framework needs to be global, and we need to have collaboration globally. FGM is everybody's business. I'll give the floor now to Toby. Toby, do we have questions for Hilary?
Yes, we do, but we have one question I didn't see earlier for Jacqueline concerning vitamin D. So I'd like to ask that quickly. Is vitamin D deficiency considered a factor in Black Asian increased risk of COVID? Vitamin D was mentioned, the deficiency was mentioned. Jacqueline, are you with us?
I'm not sure if Jackie is still with us. I can't see her name on the list. Jackie?
Okay, then because we are running out of time, Maria had a question. Maria?
Yes, and because we are running out of time, Hilary, I would suggest that this deserves much wider discussion, and I think for all those listening in, our audiences, to write to you, to give you feedback is absolutely crucial. And I should also say that we, as the conveners here of the webinar series, are thinking maybe of a follow-up kind of webinar, and I think much of what you're saying, should be brought into that. But I have one only question, and that's for me always the elephant in the room that you didn't bring into your particular exposition. Much of what we agree with, and actually our research program at King's College had, it all resonates with what you're saying. The elephant is in the room is that why FGM study, or the idea of FGM study, encounters so many problems because it's also been so racialized and so politicized, and therefore the issue of who is the knower here, the study of FGM, is right and has always been at the forefront of this particular field of inquiry, the sensitivity of who speaks here. And I just wonder how your particular suggestions for sites of knowing, for sites of study, of learning, for professionalization and so on, might run exactly into the problem of sustaining the privileged, the privileged side of work.
If I can come, first of all, let me say about vitamin D, yes, from what I've read, it certainly is important, and we can follow that up, but yes. No, I think I did, I tried to point out, in fact, in the writing that went with it, that race and gender are really important issues in this. I didn't want to overplay one against, because there's so many different ones. And my other major question was, who needs to know? If I can refer people to my website, which I will have put the thing up by this evening, because I haven't put it up before, because I didn't want to preempt the But it will be up on my website by this evening. Who needs to know is exactly what I'm asking, and who owns the knowledge and who leads it. And I certainly don't see it as just being a first world issue for interrogation. I mean, some of the best work has been done in various countries in Africa, for instance, and in parts of the state, particularly there are very good medical schools in Africa, for instance, and very good schools of anthropology in many nations elsewhere than the first world, if you want to call it that. I think that it's really important. And what I was trying to say is, I don't think this is an elephant. I think it's the reality is that different people have different perspectives, and we haven't understood that in our close clinical studies. Every single bit of clinical study is essential, because we don't want doctors doing things to us, or midwives, that shouldn't happen, and we don't want them not to do things they should be doing. That's essential. But because we've allowed it to become what I've actually called elsewhere a turf war between lawyers and medics, you know, they know the facts or we know the facts, and that's something I will put into my paper. We've forgotten that actually the facts are that there are people who've got FGM, and that is my precise point, that people who've got FGM are the people we need to be focusing on, and we need to be understanding what that means to them. And that's why I said, what does it mean to people? It's not an elephant, it's the reality, it's the light in the room, it's the window. Does that make sense to you?
Hilary, and not only does it make sense to me, it deserves wider and longer discussion, and we will give that.
Thank you.
Thank you, Hilary.
And people are very welcome to add notes. When I put it up tonight, if people want to add comments or to email me privately, I'd really welcome that. Thank you.
Thank you.
Okay.
Thank you so much. Thank you, Hilary. Thank you, Toby. Thank you, Maria. We are now going to listen to Evelyn Akkad's video. Thank you.
I hope this will work this time. I'm sorry it took me so much time to connect with you. I'm very happy to be able to present my book, L'excised, the excised, which was published in the 70s. I mean, I started writing it in the 70s. This is also when Nawal Saadawi was writing Al-Mar'a wal-Jins and talking about her own excision. So it was in those years that I became very aware by reading a book by a doctor called Yusuf al-Masri, an Egyptian doctor, and the book in Arabic was about the sexual drama of the Arab women, and he was talking about the nightmare that women suffer from with excision. And when I was a student of literature, so I was studying literature in terms of the role of women in the novels of North Africa and the Middle East, in French, Arabic, and English. But I wasn't aware of this practice, and it really shook me a lot when I read this book. And I think that the title of my novel was already in my mind, and I started writing it as I was a young professor at the University of Illinois. So I'm going to read to you now some passages from the book. This is on page 156. It's the bilingual edition translated by Cynthia Hahn. Outside, the little girls continued to howl. The women sang and chanted in rhythm to drown the howling of these young girls whose life had just been cut. That joyous trembling, the exchange of the amorous look, the call of shared desire, the voice of the wanted, the gift, request expressed without fear or modesty, the shared drunken ecstasy for the accomplishment of different gestures in harmony, for a common song, for a common light, for a victory nourished with love. For freedom woven with tenderness, for equality respecting the difference of the other. And Eve vomited once again. She put her hands over her ears so as not to hear the howling that resonated in her depth, wounding all the internal fibers of her being, and which mutilated with her the weakness, goodness, sweetness, perseverance, honesty, and love. These qualities she had tried to cultivate despite the hatred surrounding her. She pressed her hand against her ears, and she spit into the bowl, and she cried out also while spitting. This is when she witnessed the excision and then walked towards the river with women chanting, holding the bowls filled with the clitorises of the young girls who had just been excised. She cried out against customs that transform in order to cut down. She cried out against the women who mutilated their own daughters. She cried out against the men who demanded virgins, against men who wanted a circumcised one, against men who asked for a vagina sewn, shut and swollen with blood. And she cried for her helplessness. She cried for her weakness in the face of this violence and carnage she could not stop. She cried that she could not use these tears to save the girls, to save all these girls and all these children being prepared for a life with bloodshed. How could one revolutionize a world that perpetuated violence and war under the pretext of revolution? How could she stop this mutilation before it would bring about others? Take my tears to wash the blood. Take my hands to stop the knife. Take my voice to hear a new song above the screams. Take the bird and give it space to fly in a blue and harmonious sky. Take the tree and plant it in the desert near the bird. What I wanted to talk about also is this question of excision became a central debate in intellectual circles in the States where I was teaching in the 80s. I remember being torn apart myself in one of the meetings of the African Literature Association in Madison, Wisconsin in those years, where I was on a panel with several other professors, and I had talked about excision. And one of the professors there, an African man, attacked me or reproached me by saying, "Oh, this is tradition," and I was telling him, "No, it's mutilation," and he was continuing to say, "No, it's tradition." And we entered into a heavy debate about this question. And what upset me was that the room, the attendance, in the attendance there were a lot of African women, and one of them with a beautiful boubou stood up and said, "Je suis fière d'être mutilée. I'm proud to be mutilated." So I just didn't know what I could do in front of such argument, in front of such statement. But in the evening, there was a poetry session, a reading session, and I sang one of my songs on genital mutilation, because I write and compose songs. And that same woman was crying. Many of the women there were crying as I was singing that song. And she came to me afterwards and she said, with tears in her eyes, "Evelyn, You are right to denounce this practice, but in front of my Africanist or African men, I have to be loyal to them. So this raised many questions in my mind, you know. What is more important, loyalty or justice? It's one of the chapters in one of my books on sexuality and war. And I often ask my students, what is more important, justice or loyalty? Also, it became evident to me that often art, whether songs or poetry, have more strength than words or discussions. They have a power that words often don't have. Anyway, I will proceed to read another passage of my novel, L'Excisé, the Excised, in bilingual edition. And this is the passage on page 114, where the main character meets an Egyptian woman who's traveling on the boat where the main character is traveling to, and they share a friendship, and then this woman disappears. This is the woman, the Egyptian woman, talking to the main character. Do you know what they do to women there when they reach puberty, or even before, or before their wedding, if by chance they have managed to escape the surveillance of the elder women? Do you know the suffering within the flesh, the burning, the tearing, the removal of that delicate, sensitive organ lodged between two legs, the excision, the ablation of the nerve called clitoris, the button of desire, and the inner and outer lips also cut, mutilated, excised, and the bleeding wound which bleeds and bleeds unceasingly, and the days and weeks of not moving in the darkness, legs tied together with ropes, body racked with spasms, and the feeling of terrible, terrible shame, and the women's screams, and the sharp, unending pain, when you know that your body will never be the same again, when you feel that someone has taken from you something that gave you the power to vibrate, to be aroused, when you are afraid to die from all this blood escaping from your body, when you know that your body has been broken, that you have already been violated, that someone has taken from you a part of your life, and that in its place they have sewn you up, tied you, closed you up, so that you can never again breathe, open yourself to life, to tenderness, to the dew of desert mornings. And the women scream, 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 cry out, happy to avenge themselves of what life has deprived them of. These women are also happy to see that the blood continues, that the suffering has not stopped with their own body, and that the infernal circle is perpetuating itself, turning and turning and turning and turning. Just what do you think you are doing? Why don't you break the circle as I have done? Why don't you revolt before it is too late, before you yourself are excised? You have lived through war. You have seen the...
Right, I think that's the end of the video. Can you hear me?
Yes,
Yes.
it is unfortunately the
Yeah,
end.
that's the end of the video, and I've just got few words to say. FGM still raise many questions according to till today. And what is important? Is it the culture? Is it loyalty? And as you can see, this was in the 70s. And where are we now? We're still saying the same thing. What are we doing wrong? Or what are the lessons we've learned? And what are the way forward? what approaches do we need to be using now? Because as we know, one approach will not end FGM. I'll give the floor back to Toby and Maria to conclude. Thank you.
Thanks, Comfort. And we do need to conclude. Maria, would you like to have the last word?
We do need to conclude, and we need to conclude with a thank you to all of you who today contributed, to all of you who organized, to all of us who organized, convened, who supported us, and again to thank the Institute of Humanities Research Institute, King's College, and working in a kind of virtual and highly congenial environment that enables us to say this will not be the last event, the concluding event. We will have more, we hope, which to follow up on. And I know it came to an abrupt ending just now, but I'm so glad we had Evelyn. And as she said, you know, sometimes the way that poetry, that literature can evoke an existential state, far surpasses of what we in our social science and other disciplines can come up with. And to me, you know, that what resounded so much, that when she asked herself, listening to that conflicted woman, when she said, what is more important, loyalty or justice? That really gives us the challenge for the needed holistic approach, I feel, that takes from all our expertise, all our learning, all our background, and that must give space for that narrative, the coherent narrative Hilary asked for, in which we all have a part, a role to play. Because let's be clear, this isn't just giving over to the victims, the sufferers, because if we're all silent, we are complicit in a state of affairs. So thank you to all, and we will be in touch to see how we can follow this up. Thank you.